First of all, I would like to welcome all the attendees to this first session of LTSI Masterclass series. Uh, this is one of the newer initiative of LTSI. So just to briefly highlight about LTSI initiatives, LTSI has been running the fellowship programs, uh, the observership programs for hepatitis surgeons, hands-on training programs on cadavers. Uh, and LTSI has signed up a contract with MOU with University of Maryland for an exchange fellowship for LTSI fellows and young faculty, and they'll be sending their fellows. And the first fellow will be attending Prela's Institute. I would request all the attendees to keep your mic on mute and just raise hands whenever you have to ask questions. And as far as this masterclass is concerned, so the idea of doing this masterclass is to provide in-depth, high-quality education on critical aspects of liver transplant, be it surgery, anesthesia, hepatology, pediatric hepatology, intervention radiology, so that all the topics are discussed by the experienced faculty, and the experience can be shared by all the members of Liver Transplant Society or people interested in liver transplant across the country. And we plan to run this initiative once every month on Wednesdays, evening 7 to 9. Now, since it's a new initiative, and we have Prof. Rela, who needs no introduction to this gathering. Everyone knows him and his contribution to liver transplant. And it's my honor and privilege to invite him to inaugurate this program and guide us in developing this program to a better level. I would request Prof to take over from.
Thank you, Abdeep. I'm sorry, I'm still in my car. It's going to take another 10 minutes, but I was just going to give an introduction for about 10 minutes. So by the time I reach home, I think it'll be time for Dinesh to give a talk. And thank you for this initiative. And actually, I want to thank everyone who's joined in. There are 71 people joined in. I thought these days Zoom meetings were not so popular, but this shows really how keen people are in learning about subjects. And I hope this will continue, and I'm sure this will continue if the program is very educational. And it's appropriately called the masterclass and I presume this is for fellows, and I also presume that there are more than fellows in this audience. And I want to really give an overview of really what I'm not going to give you slides. I've been in this field now for 34 years, I think. So just to give you an idea of how things were when I started and how things are now, that perspective I thought would be important. Now, I started liver transplantation in 1991 in King's College Hospital. And I joined King's 1.5 years after and transplants. Now, immunosuppression those days, you read all the papers. The terminology used was a triple immunosuppression. We had standard cyclosporin, and then azathioprine and prednisolone. Prednisolone were used at high doses, really, 2 milligrams per kilogram body weight. I think some renal people still use 2 milligram per kilogram body weight. I don't think, the maximum dose nowadays we use around 20 milligrams. And that was the level of immunosuppression to begin with. And then almost 6-7 years after I went into transplantation, tacrolimus was, as you know, tacrolimus FK506. I don't know if you guys know the terminology, and FK506 as a name for many, many years. And it was really, cyclosporin was introduced by Professor Roy Kahn in Cambridge, and King's and Cambridge were a common program at that time. And then FK506 was really introduced by Professor Thomas Starzl and Astellas, which was called Fujisawa at that time. The company was called Fujisawa. And I think tacrolimus was probably the most important drug. Now, when you look at new drug discoveries in the field of transplantation, you shouldn't mistake that the drug that is discovered should be more powerful and prevent rejection. As you all know, the drugs should prevent rejection. At the same time, they shouldn't be potent, so powerful that patients succumb to infection, which is why really the combination of drugs came up. Now, when tacrolimus was introduced, I mean, it came with IV tacrolimus to begin with. I still remember using my first dose of IV tacrolimus, and that shut the kidney down instantly. So, I mean, very quickly, the IV tacrolimus went away the market because it was too dangerous, because the Cmax reached very rapidly and killed off the kidney. Now, the advantage, so they had a head-to-head trial between cyclosporin and tacrolimus. And at that time, Sandoz also had, I don't know, strangely, many people nowadays don't even see the differentiation of Neoral, which is a microemulsified cyclosporin, and standard cyclosporin, the Sandimmune. I think people are still using Sandimmune, but Sandoz kept the form which was the microemulsified Neoral, just as a competition for tacrolimus. So they didn't actually use the Neoral for participation in the trial with tacrolimus, and the cyclosporin lost miserably to a head-to-head trial with tacrolimus. So that was really the end of cyclosporin, at least in the field of liver transplantation. Now, what was the outcome of that trial? I mean, the European and the American trial. The survival difference was almost 10% at 3 years between cyclosporin and tacrolimus, and most of the survival was because tacrolimus almost eliminated chronic rejection as a problem. So when I went into transplantation, chronic rejection and retransplantation rate to chronic rejection was almost 15%. I mean, that is unimaginable. So if you look at the retransplant papers in the early days, the most common indication for retransplant was primary non-function. So the retransplant rate in our days were pretty high, eliminated it. And the second drug that was used in combination with cyclosporin was azathioprine. And azathioprine had severe bone marrow depression. So again, when tacrolimus came, we were able to use tacrolimus without a second drug. I mean, we used steroid for a short period of time, and within, I mean, this is what I presume most of you would follow, steroid for a period of about 3 months. And then most patients are on tacrolimus. And even today, you are able to maintain the majority of the patient on monotherapy with tacrolimus on a reasonably low dose of tacrolimus. Now, tacrolimus also really yielded for additional drugs to be added for other reasons. For example, renal protection. And before, with cyclosporin, you couldn't lower cyclosporin with azathioprine. You couldn't lower cyclosporin level. Now, because to use tacrolimus on its own, you can add a small dose of MMF and then reduce the tacrolimus dose to a level where you can really maintain them on a level of 2 or 3. And that actually gave a huge option to improve renal function in patients. And nowadays you've got and you've got postponing the use of tacrolimus or CNIs in the post-operative period. There are many options are available nowadays, and I think you live in an era now where the chronic rejection rate is probably reduced to 1 to 2%. So the graft loss due to chronic rejection is completely reduced. And really, the 5 year survival on my earlier days was about 60%. Nowadays, you can expect a 5 year survival of close to 90%. So, really, improvement, I believe, improvement in immunosuppression, perhaps some reduced technical complications have made a difference. Now, the only advice I often see patients from other units these days. Almost, I mean, I used to have one or two patients, I mean, one patient a week sometimes, or at least two patients a month. But patients have been managed with really very powerful immunosuppression and coming with very cholestatic picture. And we are able to manage their immunosuppression and make them better. And I just want you to really learn the art of immunosuppression. There is something I would like to tell you. When there is a combination of diseases, and the example I want to use is hepatitis C, many of you may not have now, you don't see that many patients with hepatitis C. And even if you do, it is treatable now. You can clear the virus before and if not even after transplant. But we lived in an era of treatment. Majority actually of the patients transplanted were transplanted for hepatitis C, and recurrence of hepatitis C was universal after transplant. And when you get recurrence of hepatitis C after transplant, you got patients who got very cholestatic. And the differentiation between rejection and cholestasis due to recurrence of hepatitis C was very difficult. I don't know if you know the story of hepatitis B before immunoglobulin era. And really now we are in a much better position. Hepatitis B used to be a contraindication for transplant. And when you got a recurrence of hepatitis B in the post-transplant period, you get a fibrosing cholestatic hepatitis, which almost carried 100% mortality. And cholestasis is a very common feature in recurrence of viral infection. And you must consider yourself lucky that you're not having to deal with these patients. And invariably, people mess up treating these patients. The immunosuppression is withdrawn. And then you think you've got a bit of rejection. And then you don't know what to do. There is no treatment for hepatitis C. We didn't have any treatment for hepatitis C. You just have to manage immunosuppression, reduce immunosuppression in order to get hepatitis C under control. And we really had a huge problem in managing these patients. And now, what I see with living donor liver transplantation, the cholestasis that you see is very often due to biliary issues or bile leaks, and people mistake it for rejection. And if they don't have good pathology, and many of you I'm sure are treating rejections based on blood tests and not on biopsies. So if you do have additional complication, I think you should confirm rejection and not treat rejection without confirming histologically. And I'll tell you why. Most of the patients that I see who have been mismanaged have had ATG, they've had OKT3, they've had everything thrown at them. And I want you to understand a disease process of intense immunosuppression. It is very similar to HIV cholangiopathy. So if you intensely immunosuppress somebody, they will also get cholangiopathy and get cholestatic. And if you withdraw their immunosuppression, their cholangiopathy would improve. So many patients get intense immunosuppression unnecessarily, and then they get cholestatic and they get biopsies, and people don't know what is going on, whether it's a biliary complication or not. And you put stents in. If you put stents in, um, the really the immune associated intense immunotherapy associated cholangiopathy won't improve with your stent. Just not understanding what your problem is and just increasing immunosuppression with the hope that the patient's going to get better is not going to get better. So really, I mean, these are my thought processes. And today we are in a much better situation with immunosuppression, but it is really understanding immunosuppression, which is most important in managing patients. Over immunosuppression is not a solution to ongoing rejection. And very often you need to titrate them and lower immunosuppression to see if they will improve. I think I will stop with that. I've reached home. I'm just going to go up. My car has stopped now. I'm still sitting in the car. And Dinesh, I hopefully will give you a good idea of the basics of, I think, immunology and how standard immunosuppression is going to be. And then we'll have some, maybe a couple of case discussions about post-transplant immunosuppression and how we manage it. Is that okay? Abhidip, is there
Yes,
anything else you want to ask me or say? I thought I'll just give a historic perspective of how we have got to where we are.
I really appreciate your kind of wisdom and the kind of experience you shared. And these are very important things to know for everyone who's starting to practice in the field of liver transplant. And really thankful that you were available to share your experience. I would request you to continue and give your expert comments when we go on the next
Yeah,
part.
I'll be there throughout. Don't worry.
We
We'll
have
talk.
100 plus participants, and I'm really
Oh,
happy.
it's
Yeah,
very encouraging for me to see 100 participants there for this actually.
right.
This is like a COVID time now. All right. Thank you.
I would now invite Dr. Dinesh. He's a senior hepatologist, director hepatology at Dr. Rela Institute, a very experienced and a very dear friend. I'm always very impressed to hear him talk about various aspects of liver transplant, and I would now request Dinesh to give us a brief about immunology and immunosuppression in the field of liver transplant, and then we're going to discuss a few cases which Naveen is going to be talking about. So over to Dr. Dinesh.
Thank you, Abhidip. Thank you, Prof. That was just wonderful words of wisdom and overview of what we're going to talk about today, and that was it was just out of the world, and we really enjoyed that. So
Yeah,
what?
there was another thing I wanted to say as well, because today we are so used to having single immunosuppression. This is often what I see in our unit. Neurological complications seem to be more common in our part of the world than I have seen in the West. And we have got many patients who are converted to cyclosporin from tacrolimus. Yes.
Yes, Prof. Hello.
Yes, Dinesh, we can hear you.
Phenolate and
No, no,
steroids
Prof.
back. Pardon?
No, no, Prof. You were saying I couldn't hear you.
I'm saying don't forget to reintroduce a small dose of MMF or steroids when you're converting a patient from tacrolimus to cyclosporin. Often we forget. Can you hear me?
Uh,
Yes,
I'm
Prof.
just going
We can hear you.
upstairs. Yeah. This is another mistake that commonly made is assuming that cyclosporin is exactly the same drug as tacrolimus. It's not. And the other advice I would give to people who have been converted to cyclosporin from tacrolimus because of early neurological complication is to reconvert them back to tacrolimus after 6 months or 1 year, because we know that the cyclosporin based immunosuppression has got a much higher chronic rejection rate. So that's another thing that I want people to remember. Okay.
that's wonderful, Prof. Yeah, that's really good.
Go on, you go on.
Sure. Thank you, Prabha. Just share the slides. Can you see my slides? Or
Yes,
correct?
yes, I can see your slides. Just make it a full screen.
Just I can't see. 1 minute. Just reshare.
Right.
Yeah. Thank you, LTSI, for this wonderful opportunity. And you heard from Professor Rela about how the immunosuppression has evolved over the years, and just beautifully narrated his experience with the immunosuppression in patients who had liver transplantation. The survival of liver transplantation has significantly improved over the last 30, 40 years. The reason for that is multitude. One, appropriate recipient selection, improved surgical techniques, and betterment with post-operative care. And the other important aspect to remember is the change in the immunosuppression during this period of time. If you look at the literature, the 1-year survival following liver transplantation in 1980s were around 66%. But nowadays it's close to over 95% in most centers. And these are the reasons why the survival has significantly improved. And the contribution by the availability of CNI-based, calcineurin-based immunosuppression has changed the outcomes completely. Nowadays, we don't see that many rejections, and rejection rates have come down significantly. But nevertheless, it's important to understand what immunosuppression involves, and also the drugs, how we manage these patients. So when a patient undergoes a liver transplantation, I just want to go through 3-4 slides about the basic immunology as what happens. When a patient undergoes liver transplantation, the recipient will have donor-derived liver tissue, donor-derived immune cells, and vasculature. And that liver will receive blood from the recipient and immune cells from the recipient, apart from your protein and other substances, immune cells from the recipient. So you have a situation, you have donor liver tissue, you have donor immune cells, you have recipient immune cells. How they are going to talk to each other, how they are going to interact with each other, it defines how the graft is going to function. For example, if the recipient T cells enters the donor liver tissue, the first cell it's going to come in contact is the dendritic cells. Dendritic cells are nothing but monocytes that are derived into antigen presenting cells. Their role is only to present the antigen to the T cells. So this is the first point of contact. So this is called direct interaction between the donor dendritic cells and the recipient T cells. What happens when these donor dendritic cells and the recipient T cells interact? They're going to have an argument. They're not going to settle down. They're going to fight and end up with some injury. But if you look at the overall picture, the amount of immune cells, particularly the dendritic cells, are not many compared to the liver tissue and other cells in the liver. So there is a direct interaction. There is direct interaction mediated injury, but that's not going to harm the liver. Okay, harm the graft. The second possibility is what we call as indirect interaction. Indirect interaction, it's between the donor-derived peptides and the T cells. See, you have to understand the liver cells can release proteins and peptides and little bit cell damage. Those peptides are processed by the dendritic cells and present to the T cells. So this is a possibility. So the one, you have direct interaction between the donor dendritic cells and the recipient T cells. Second, you have the interaction between recipient dendritic cells and the recipient T cells. The recipient dendritic cells can actually present the donor peptides. Hope you understand this. So this is a direct and indirect interaction which happens in the initial phase. So if you look at this slide here, the direct pathway where the donor APCs, antigen presenting cells, directly interact with cytotoxic T cells, and the damage can be severe. But the chances of this happening are very less in terms of the percentage, because the number of donor APC cells are not that significant compared to the whole liver mass. So we don't see much injury because of this. Now, the second possibility is donor-derived, that is donor antigen presenting cells, become friend with our recipient T cells and present the donor-derived peptides to the T cells. Either this is happening, or the recipient-derived, that is the dendritic cells from the recipient, interact with the donor graft cells, and then those peptides are presented to the T cells. So this is the most common pathway that is contributing to the immune regulation of the graft in liver transplantation. So this is very important to understand this. So it's not the direct pathway that's contributing. This indirect pathway through the recipient APCs and through the donor APCs. These are through what we call as MHC class 2 molecules. MHC class 1 is present in almost all nucleated cells, and they take their antigens as intracellular peptides, whereas the class 2 are the peptides released in the substrates. So they cause the T cell interaction present to the T cell receptor, and they activate more T lymphocytes, leading to rejection. Among the indirect pathway, there are 3 types of signaling. Again, I'll show in the next slide something very similar. So all these are through class 2 antigens. First, when the APCs along with the antigen are presented to the T cell receptors, this activates T cells through calcineurin pathway, which is an intracellular pathway. Intracellular pathway. That is, but not intranuclear, intracellular pathway. Now, whenever there is interaction between antigen presenting cells and the T cells, there are other molecules released. Okay, so whenever this is attached, there is activation of other molecules like proteins like CD40 and CD8086. So this is like extra attachments. It comes as a package. So this is signal 2 transduction. The first is called the signal 1 transduction. The second is signal 2 of activation. And whenever there is a damage between or interaction between the dendritic cells and the T cells, the substrate releases pro-inflammatory cytokines. We know that there's an inflammatory milieu. So there is a release of pro-inflammatory cytokines. And one such is powerful is interleukin 2. You know where I'm getting at. So this is a signal 3 activation of T cells. So the T cells can be activated by signal 1, signal 2, and signal 3. Signal 1 is the direct interaction through donor-derived antigens. Signal 2 is co-stimulatory. Signal 3 is what is available, the protein substrates that are available or antigens that are available in the environment through IL-2. So this is what I spoke about just now. So why this is important? Because if an antigen presenting cells, okay, interacts with the recipient T cells, this is called priming of naive T cells. This process is called priming of naive T cells. If you prime a naive T cell, this triggers activation of the T cell through three major pathways, but predominantly through calcineurin. Remember, our calcineurin inhibitors are the cyclosporin and tacrolimus. This is a calcineurin dependent pathway is activated. And this is signal 2 activation. This is signal 3 activation. Signal 3 activation is through interleukin 2. And that's how these drugs are coming to play. Say, for example, if we have calcineurin inhibitor, we have corticosteroids, which acts at the intranuclear level, which inhibits your nuclear factor NF-kappa B pathway. Whereas interleukin 2 inhibits your mTOR pathway. So these are very much linked mechanisms. So you can use mTOR inhibitors, you can do IL-2 receptor blockage, or you can use corticosteroids, you can use calcineurin inhibitor. So that's how these drugs are derived. Or if you want to sort of destroy the entire T cell lineage, you can use your depleting antibodies, polyclonal and monoclonal antibodies. So these are the currently available immunosuppressive medications. 1, corticosteroids. 2, your calcineurin inhibitors, which are tacrolimus and cyclosporin. 3 are anti-metabolite drugs, which acts at the nuclear level, and mTOR inhibitors and IL-2 receptor antagonists. These are biologicals. The last one is a biological group of drugs. The transplant outcomes have improved over a period of time, over a period of last 30, 40 years, because of introduction of these drugs. So the first drug introduced was corticosteroids and azathioprine, where patient had first kidney and successful liver transplantation, then came your cyclosporin, eventually your tacrolimus. After introduction of tacrolimus, as Professor Ella said, the outcomes of the survival outcomes have significantly improved over the year, both short term as well as the long term. Now, when you see a patient or a recipient following liver transplantation, when you want to know how we are going to manage the immunosuppression, because you got a baggage of drugs, steroids, cyclosporin, tacrolimus, all this antimetabolites. What is that you're going to use that patient, and what are you going to achieve? So therefore, we need to be very clear in our mind the goals of immunosuppression. Obviously, the first goal is to maintain normal allograft function. That's the most important. So if you look at the short term, yes, you need to have the normal allograft function. The liver should be normal. That's your first goal. And what is your second goal? That's the long term you're talking about, and as well as in the short term, to reduce the complications of the immunosuppression. So you should have a fine line between maintaining a normal allograft function as well as to reduce the complications of immunosuppression, because these are little powerful drugs, and not only it can affect, improve your graft function, but it can lead to some untoward complication, mainly renal, steroid complications. We all are quite familiar. So when we see a patient following liver transplantation, these are the general protocols. Okay. However, this should be tailor-made for individual patients. Your steroids are the main drug in the initial phase. So all patients receive intraoperative methylprednisolone, all transplant recipients. And then what happens in the first 3 months, because it varies between different times. I'll tell you in few slides how we can manage these immunosuppressive medications. So these patients receive methylprednisolone during intraoperative period. And for the first 5 days, they receive till they take adequate oral intake. They'll be on methylprednisolone, 16 milligrams, which is equivalent of oral prednisolone, 20 milligrams for 4 weeks, and taper over the next 6 to 12 weeks. And start tacrolimus on day 1 between 0.5 or 1 milligram twice a day. Check trough levels after 4 doses. Maintain a trough level of 6 to 8 or 8 to 10, depending on the indication and depending on what we want to achieve and what other complications the patient have. Again, I'm saying this is a rough protocol, but it should be individualized to a patient. If the patient has higher requirement for higher immunosuppressive medication, then we can add second group of drug like antimetabolites, like mycophenolate mofetil, such as in patients with autoimmune liver disease. Or as Prof. Relas said, like, you can maintain lower tacrolimus level. Previously, the teaching was to maintain higher tacrolimus level, but over a period of last couple of decades, I personally witnessed the tacrolimus levels we maintain these days are much, much lower than what it used to be. That's because of usage of the combination of drugs. 3 or 2 low dose drugs have a lower side effect than a single higher dose medication. So in the first year, you maintain tacrolimus between, if they are on a monotherapy, you maintain 6 to 8 nanogram per ml, and higher if they have autoimmune hepatitis or a recurrent T-cell mediated rejection. Add another second drug, to keep lower tacrolimus level. Say, for example, if these patients have renal impairment or hepatocellular carcinoma. Patients who are on MMF, generally we continue up to a year. We can attempt stopping the immunosuppression, the MMF. Never stop tacrolimus, Dr. MMF. But if they need 2 dual drugs, then you can maintain low TAC with low dose MMF. So this is how we maintain the first year. Corticosteroids are not required for a long period of time. If you transplant patients for NASH-related cirrhosis, they are prone for metabolic complications. You can taper steroids in 6 weeks. Whereas if you have patients with autoimmune liver disease like PSC or autoimmune hepatitis, or if the patient has recurrent T-cell mediated rejection, then we can continue with the low-dose corticosteroids. Particularly for autoimmune liver disease, you must continue steroids. Although there was some recent discussion, what Dr. Neeraj Saraf was saying, that ASLD guidelines says, we can taper steroids, but generally the rule is to continue steroids. If you have somebody transplanted and following up in the long term, then you have to maintain lower tacrolimus level, particularly around 4 to 6 if you're using monotherapy, and 3 to 5 if you're using dual immunosuppression, particularly if you're transplanted them for hepatocellular carcinoma outside criteria. Now, that was the basic protocol for immunosuppression management. So when you see a patient, we need to know what was the indication for transplantation, what is the time from transplantation, how is the allograft function, and what comorbidities the patient has. For example, is the patient diabetic? If the patient had preoperative renal dysfunction, or the patient just recovered from sepsis and undergoing transplantation. And also, what are the drugs the patient is taking? Sometimes there can be drug-to-drug interaction. Or is the patient obese? So all these should be taken into consideration. It's not just you just start them blindly. So you need to go through that individually with the patient and then start them accordingly.
Dinesh, can I interrupt?
Yes.
Can you go back to the first slide? I just want to make a point there. First immunosuppression slide. Yeah, no, the yellow one. At the bottom, clinical slide.
Yes, Professor.
Yeah, this one. I just want to say, I mean, there have been a lot of discussion on the use of the prednisolone in transplantation, and there are even papers on steroid-free immunosuppression. And I said that earlier on we used to use 2 milligram per kilogram body weight of prednisolone, not methylprednisolone. But there is this high dose that you see that is given pre-reperfusion, intraoperative methylprednisolone of 500 milligrams. And we used to use 1 gram actually, rather than 500 milligrams in the cadaver transplant. And there have been some discussions with some of the surgeons I know who felt that we should avoid using steroids and not given that intraoperative. Now, the purpose of the intraoperative high-dose methylprednisolone is not just immunosuppression. The main purpose is mainly in the cadaver setting where you got marginal livers, is to deal with a cytokine storm and the severe hypotension that you get post reperfusion. So if you stop that drug and if you have not given methylprednisolone pre-reperfusion, you might have an intraoperative cardiac death at the time of reperfusion. So don't think of that as an immunosuppressive drug. It is a drug that is used to reduce the risk of severe reperfusion syndrome. So I just want to say that to people. Okay.
Okay.
And okay, in the long term, we can talk about the long term, how manipulate it. Okay. Go on. Sorry for interrupting.
Sure. Yeah. So when you use tacrolimus, we should be very careful about the renal function. Why? Because renal dysfunction occurs both acute as well as chronic. In general, around 13% of patients or recipients can have renal dysfunction by 3 years, and around 25 to 30% by 10 years. And very rarely patients may require, dialysis, etc. The acute renal dysfunction associated with tacrolimus is quite reversible, whereas a chronic injury is irreversible. The acute insult is because of severe afferent arteriolar vasoconstriction, whereas the chronic is more of tubular interstitial fibrosis. Tubular interstitial fibrosis. Therefore, it is less reversible injury, whereas acute is that occurs mainly in the first few weeks after liver transplantation. And CNI is considered to be the most important risk factor for nephrotoxicity in post-liver transplant patients. However, there are other risk factors we should consider. One is if these patients have pre-existing hepatorenal syndrome just before the transplantation, or if they have ongoing diabetes and element of diabetic nephropathy or hypertensive nephropathy, this will also add on to the existing renal dysfunction in the post-liver transplantation period. So therefore, this is very important to address that. I've seen reports saying, patient has renal dysfunction post-transplantation, therefore stop tacrolimus, put them on mycophenolate. That's not advocated. The first thing is, yes, you may lower the tacrolimus, but never stop, but also address the other risk factors, hypertension, the weight gain, diabetes. So these factors we should never overlook. So that's very important in the post-transplant phase. So we have lower lower tacrolimus-based immunosuppression for who we think the kidneys should be spared in the long term. So the options are, we can lower the tacrolimus, add another immunosuppression, and address the risk factors such as obesity and diabetes, hypertension, etc. Has this been studied? Yes. So this study looked at the combination of mycophenolate mofetil with low-dose tacrolimus with tacrolimus. So this is your tacrolimus arm, then this is your low-dose tacrolimus arm. So if you look at the study outcome at 48 weeks, there is a significant improvement in renal function in patients with who receive low-dose tacrolimus and mycophenolate. However, there is some reduction in the diabetes, hypertension, but nothing much difference in terms of the diabetes. Therefore, low-dose TAC protects your kidneys, but you should not give low-dose TAC by compromising your graft. So therefore, you should add another drug to it. So that's a learning point. Now, can we add everolimus, which is mTOR inhibitor? And we use that more often these days. So this prospective multicenter trial, looked at tacrolimus monotherapy versus low-dose tacrolimus with everolimus. So the tacrolimus level they maintained in the first 12 months post-op was around 6 to 10. In patients with low-dose tacrolimus, the level maintained was between 3 to 5, along with everolimus. As you can see, at every time point, there has been a significant improvement, significant difference, and with improvement in the kidney function in patients who received low-dose tacrolimus with everolimus. So therefore, first point is you need to maintain normal liver function, allograft function. Second is to protect your kidneys. So therefore, if the patient has risk factors, better to add second drug to keep the low tacrolimus and then continue and monitor them, and also address other metabolic parameters. This is what we spoke about as a renal sparing one regimen. Now, as a start, can you delay your tacrolimus? So this has been studied in 2011. So where patients received IL-2 receptor antagonist, basiliximab, and delayed the onset of CNI by day 4 and compared with standard therapy. So what you can see in this study is over a period at various time points, again at 1 year. So at baseline, basiliximab patients had higher renal dysfunction compared to the controls. But over a period of time, they stabilized actually. Both had similar outlook. So therefore, basiliximab actually protects your kidneys, particularly in the early postoperative period. And over a period of long term, you have to address your other risk factors. Now, we keep talking about the renal dysfunction associated with tacrolimus. And people have experimented with once-a-day tacrolimus, that is prolonged release tacrolimus, that's what we call advagraph that you use. Because the pharmacokinetics of tacrolimus metabolism says when you use twice a day, your trough levels vary significantly between the morning and the evening. Whereas if you use a prolonged release, your trough level is more or less stable over a period of time, which is considered safe for the kidneys. So this multicenter trial, where patient received twice-a-day tacrolimus versus once-a-day tacrolimus. Both had similar renal function. Both did extremely well. If you look at the rejection rates are very similar, but renal functions were very similar. But in addition to the advantage of taking once-a-day tacrolimus, there is improved drug compliance. So that was the outcome of the study. So although the study aimed at improving the renal function, what the outcomes showed was a secondary outcome. There's a significantly improved drug compliance for this drug. So therefore, once-a-day tacrolimus usually we use in patients in young adolescents where they may not be compliant with medication for a long-term period, and they may go to university and going out with friends and may stop the drug. So therefore, this long-acting tacrolimus is quite useful in patients, in the younger population in particular. Now, the other important complication of calcium inhibitor is, as Prof said, neurotoxicity. It's again, this is more common with tacrolimus than with cyclosporine. Usually, it will be like a headache or paresthesia or bilateral tremor or insomnia. And most of this settles after a few days or 2-3 weeks like that. However, there is something the complication can be very severe, which is posterior reversible encephalopathy syndrome, or otherwise called PRES. It has a variable spectrum. The patient can have severe headache to seizure, altered sensorium. They have blurring of vision, cortical blindness, and they slip into coma. This PRES, it's very unique to CNI. However, this was first recognized not in transplant patients. This was first recognized in patients with preeclampsia when they have fever, when they have seizure. And there they found patient has severe cerebral vasoconstriction and sudden increase in hypertension, and which causes significant damage to the blood-brain barrier, leading to edema of the brain. It's not like cerebral edema, more of a vasogenic edema. Okay, the similar process has been identified in patients with the CNI-related neurotoxicity, which is defined as PRES, where the MRI will show parietal or occipital lobe hyperintensity, T2 flare. So the treatment is to switch to cyclosporine, okay, in the short term. This is a very short-term management, and add anti-epileptics, and of course give them physiotherapy, improve them over a period of time. Most patients recover over a period of a couple of months or 2-3 months like that, and then they improve completely. But as Professor Ayla mentioned earlier, don't keep them on cyclosporine on the long run, because cyclosporine is associated with increased risk of acute cellular rejection. After 6 months or 8-9 months, we should try and switch them back to tacrolimus. And we have seen that these patients tolerate the drug much better when we start late, actually. So, particularly who have CNI-related neurotoxicity. And if you keep the patients on cyclosporine, do not keep them on monotherapy. Always it should be dual or triple regimen. There should always be some element of corticosteroids, like 5 milligrams maintenance, because the risk of rejection with cyclosporine is high. This is the study what Prof mentioned earlier. So there was a head-to-head comparison of tacrolimus versus cyclosporine as an immunosuppressant in liver transplantation. It's an open-label study, around 260 patients, both groups. If you look at the study outcomes, there was a significant increase in rejection rate, acute cellular rejection or T cell mediated rejection rates with cyclosporine over a period of time compared to tacrolimus. Therefore, it's better to add a second drug to patients who are on cyclosporine monotherapy. Never keep somebody on a cyclosporine monotherapy. That's the point we should highlight it. And whenever feasible, switch them back to tacrolimus. That's a very important point. Because if you keep them on cyclosporine, still the rejection rates are high. The complications may be a little higher over a period of time. So therefore, immunosuppression is very much tailor-made. It's not for not protocol-driven, although protocols guidelines exist. It should be pretty much made for the individual patients. And we can go through different scenarios, like patients who had hepatocellular carcinoma, or patient who you transplant for acute on chronic liver failure. Say, for example, if you transplant somebody with acute on chronic liver failure, we know that these patients are sick from the baseline. They have severe jaundice, they've been septic, they must have had kidney injury, they may be coagulopathic. If these patients undergo liver transplantation, the risk of sepsis can be higher than the risk of rejection. Therefore, you should be little careful with your immunosuppression. If you over immunosuppress them, then it's a problem. Okay, but at the same time, you should not under immunosuppress them too much, enough to cause rejection. So therefore, you have to maintain that line. Similarly, in patients who are transplanted for hepatocellular carcinoma, if they are transplanted within Milan criteria, it's not an issue. We can use conventional immunosuppressive therapy. However, these days we sort of transplant them with UCSF criteria. We downstage them to Milan criteria and then transplant them. So these patients should be monitored very closely in the post-transplant phase, and immunosuppression should be adjusted. So we can use low-dose tacrolimus and add on everolimus. So this regimen protects your graft as well as reduces the risk of rejection. So therefore, we can use different regimens for individualized patients. If somebody who has renal dysfunction, you can use basiliximab as an induction agent and keep low-dose tacrolimus, add MMF in the long term, for the long term. Somebody who's diabetic, similarly, we need to address their risk factors such as obesity, and they need a strict lifestyle change with diabetic control and improvement in the hypertension to avoid long-term kidney damage. So all these protocols are there, but we should address it to the individual patient. Long-term side effects of immunosuppressive drugs, probably most of you know, but majority are related to metabolic syndrome. So therefore, we are increasingly more and more transplanting patients for NASH-related cirrhosis, and they have pre-existing coronary artery disease, diabetes, obesity. Most majority, they gain weight in the post-transplant phase, particularly NASH patients. So therefore, we should address the lifestyle along as and when we go monitor the immunosuppressive level, not to overshoot your tacrolimus or cyclosporin levels, and don't use the steroids where the situation doesn't warrant, and monitor the blood pressure, use appropriate antihypertensive medications. Because what happens is, what I've seen is, patient with borderline kidney injury goes and meets his nephrologist, and the nephrologist blindly say, this is because of your immunosuppression, tacrolimus. So the patient have inclination to stop the drug, and that's not what we do. So we reduce the dose, add another drug, and address the risk factor. So we should not stop tacrolimus in these circumstances.
Dinesh, can I just add one more comment, please? Now, you were talking about tailored immunosuppression, and every individual is different. That's why the doses and the drug levels, tacrolimus level, are not the standard. I mean, we have a guide of early post-transplant 5 to 8 and 3 to 5. And I want people to understand that there are some people whose enzymes will become abnormal if they drop below 5, and they always require above 5. And there are some who won't show any abnormality even when the levels drop down to 2 or 3. So it's better to see that everybody is different, and you don't need to standardize that everybody has to have a level of 5 and above. And that's how you really play with immunosuppression, but don't play too much with immunosuppression alone, immunosuppression as well. Now, you could get into a situation where the patient's not taken the drug and the levels are hardly measurable, or it's less than 2, and still they haven't had a rejection. And you could argue that some of them may be partially tolerant and may not require much immunosuppression at all. But that shouldn't really make you feel that it's safe not to have them on much immunosuppression. So somebody who's on very low immunosuppression with very low drug levels, having good graft function, doesn't mean that it's a stable situation. That's what I want to say to people. And the withdrawal of immunosuppression studies this is one of the problems, that just having normal graft function with very low immunosuppression or no immunosuppression is not a stable situation. And all that they have to get is a viral infection. And any viral infection can then trigger a rejection, and they will come back to you with serious rejection. And late rejections are always much, much more difficult to control than early rejection. So don't be carried away that you are able to lower immunosuppression in a patient and they are actually having stable graft function for a long time. So do look to see how low you can go on immunosuppression, but that doesn't mean that you can gradually take them off or keep them on a very, very low level of immunosuppression. I just want to put that as a question.
Yes, Prof.
Thank you.
Thank you. So therefore, so what is the optimal immunosuppression? So too low can be a problem. That's what Prof. was saying. Because if you go too low and if they have allograft dysfunction, it can be actually very difficult to manage. At the same time, very high immunosuppression can cause problems even within the graft, as well as the risk of opportunistic infections. So therefore, the immunosuppression should be made for the individual patient. That's the whole concept of this talk. And it's dynamic. It's not the same thing what at the earlier phase compared to the later phase. So somebody who may require higher immunosuppression in the early phase may not require high same level later on. So therefore, it's not just like one snapshot. So you need to follow them over a period of time and understand the pattern, what they require, these patients require. And this is where the follow-ups are extremely important. And you should engage them. And every time we talk about being compliant with the medications. And also we do sort of annual health check to look for, is there any hypertension related cardiac changes, renal changes, urine protein creatinine ratio, how the diabetes, the hemoglobin A1C levels. So all these small parameters are very important, very crucial. And also we do DEXA scans if patients who are on steroids, because it has to be treated at the earliest. You don't want to be in a situation where we are struggling what drugs to use after 2 years after transplantation. So it's important they are on a very stable drug over a period of time so that they can carry on with their normal lifestyle. And also, at the same time, you need to monitor them very carefully for a period of time. So this is what I'd like to conclude. Last couple of slides. This I want to specifically add Charles's study, sort of paper from JCH a couple of years ago, where he nicely spoke about all the immunosuppressive medications. The two drugs that we should be familiar with, your anti-thymocyte globulin and basiliximab. So these are the biological group of monoclonal antibodies. ATG used in patients with severe refractory rejection that you are not responding to high doses of corticosteroids. However, these are, as Prof said earlier, we see a lot of patients getting these are very rarely used drugs. But when patients come to us, we've seen that more patients have received ATG, and this can just wipe out your T cells completely and cause more problems. So therefore, we should be very, very careful in using these drugs in the early post-transplant phase as well. So therefore, I would like to conclude saying immunosuppression forms the cornerstone of post-transplant management. It's very important to understand the patient, understand their need, how to maintain the allograft function, and and address the comorbidities both in the immediate, short term, and in the long term. So the first goal is to maintain normal allograft function. The next is to optimize the kidneys, particularly diabetes and hypertension control. What I would say is 2 smaller doses are better than a large single dose to avoid complications. But at the same time, you should maintain normal allograft function. That's our first priority. Other things can, considered late. Thank you very much once again for the opportunity. Thank you.
Dinesh, can I just clarify just one more point about long-term steroid use? I'm actually in children, I mean, maybe Naresh may not agree. At King's, we have always used a low-dose steroid for children. One of the things about long-term graft fibrosis, I think Mukul wrote a nice paper on that, long-term graft fibrosis, reasons for long-term graft fibrosis. Particularly children who are going to live for the next 45, 50, 60 years. I believe that a very small dose, even a 1 milligram of prednisolone, makes a difference in reducing the risk of long-term graft fibrosis. And the other thing I want to say, particularly in autoimmune patients, if you talked about bone densitometry, I think people shouldn't forget osteoporosis. And if you're on a steroid dose of more than 7.5 milligrams, and if you have not taken precautions like adding vitamin D or calcium to their prescription, and they get a fracture, technically you're liable actually that you've not looked after or prevented osteoporosis in these patients. So beware of dose beyond 7.5 milligrams of prednisolone. And I don't think a very small dose of prednisolone in the long run in pediatric transplantation is harmful. Thank you.
Yeah, Prof. When these patients come to the adult side, so, I've seen that prescription 1 milligram prednisolone, and when we talk about with stopping them because they're already on a higher other drugs, they get little offended by that because they've been taking for years, and so I just let them be on 1 milligram.
Yeah, I would leave them.
Yeah.
And the other advantage of pediatric transplant is if you maintain them on a same dose and nothing happens to their graft function, you're actually slowly withdrawing their immunosuppression as they grow.
So relatively, we're withdrawing with the.
That's right. So to leave them and for them to have a good graft function is a good situation. Okay.
Any questions, Abhijit?
Yeah, I mean, first of all, thanks, Dinesh, for a lovely talk. And I think I would request all the people who are there to please post your questions in the chat section so that we can go one by one. And I think we can start with the case scenarios, and then maybe that can we can take comments and the questions along with that. And in the meantime, while we are starting, there are a couple of questions. The first one from Dr. Sauradip Datta. Question to Prof. and Dinesh. Basiliximab is typically used as an induction agent on day 0 and day 4, sometimes day 1 and day 5. However, can it be administered later in the course beyond day 5 or within 60 days if the patient is unable to tolerate CNI or everolimus? Would this allow for a CNI everolimus-free period, maybe 1 to 2 weeks, to help manage renal, neurologic, or cardiac complications? And the second part of the question is, if the basiliximab is unavailable, can MMF be initiated from day 1 as part of renal sparing protocol?
The first question is, Prof, do you want to answer that? The first question, can we have tacrolimus-free period?
No, you can't. You have to give basiliximab on day 1. It's no use giving it after that. So if you lose that opportunity, I mean, you need to talk about the immunology of that. You can't use basiliximab after day 1. So introducing it after 60 days or 50 days to withdraw CNI is not an option. You have to look at other options. MMF on day, I mean, you cannot use MMF as a primary immunosuppression without CNI anyway in the early post-transplant period. So you can have a very low dose of prednisolone and then have MMF. I personally, I'm not too against MMF in the very early stages. But then the GI problems and, patients getting a bit of ileus is an issue in the first 3 or 4 days. So generally, we don't start MMF until about 5 days or 7 days if you want to start MMF. It is okay to have very low dose of tacrolimus if you have missed the boat with basiliximab.
Also, the question says, if a patient unable to tolerate CNI, so how do we define tolerate CNI? I mean, mostly it's either neurotoxicity or mild headache and tremor, and mostly it will settle down. I don't think by reflex we should give a CNI-free period. I think that's probably not recommended. So it's better to see why they're not able to tolerate, and then manage accordingly rather than stopping CNI. So role of protocol biopsies. So previously, during hepatitis C era, protocol biopsies were followed. But I think that practice has gone out of fashion because when I was trainee, we used to do lunchtime biopsies for all, 5 to 6 patients used to come every day during lunchtime, and then we do biopsies. So either it's going to show recurrent hepatitis C, subclinical, or some sort of low grade rejection like that. But again, to act on that, it's probably if it is hepatitis C, definitely we need to work on it. But again, very mild inflammation, probably we need to optimize a little bit. Once again, that practice has gone. Now we don't do protocol biopsies these days. Maybe in patients with autoimmune hepatitis, because they can have subclinical recurrent autoimmune, in the biopsies without much manifestation in the liver enzymes. But yeah, generally we don't do these days. Is that?
Yeah, protocol biopsies I wouldn't do these days. I think we used to do them at 5 years, 10 years. I think they should be reserved for only studies, actually, for the purposes of studies, because they do carry a risk, and I don't think in today's world protocol biopsies are done as a routine. I mean, there may be centers which have, but it'll be very difficult to get a consent for that in our part of the world. What was the other question?
The role of everolimus plus
There's a
MMF plus
question on
steroid.
what is the lower cutoff level, lower cutoff level for tacrolimus that must be maintained. Any comments on immunosuppression in sarcopenic patients? Observed patients with sarcopenia usually maintain normal graft function with relatively low tacrolimus levels. That is all true, actually. I think patients who are very debilitated are unlikely to reject, and therefore it's good to maintain them on very low tacrolimus level. When I say very low tacrolimus level, that I would be accepting around 2, not much less than 2. Even if the graft function is normal, when it's between 1 and 2, I would put it up to about 2. Maybe 2 to 3 would be my, less than 2 would be my threshold for putting it up with normal graft function. But you will find that patients who are really debilitated may require less immunosuppression, but as they get better nutritionally, they will reject. So you need to watch out. As their immune system improves, they will get rejection. This is the same with when you're managing PTLD patients. You withdraw immunosuppression, and PTLD improves, and over a period of time, their immune system gets better, and they will start rejection. So they need to be very closely monitored. Wherever you are managing low immunosuppression, you have to closely monitor. How early can we add everolimus after liver transplant in case of renal toxicity? You can, I mean, we would, you could add, the problem with everolimus is wound healing as an issue. I know Dharmesh Kapoor uses everolimus within 2 weeks after transplant, or even very early. I would say a month or 2 later would be okay to add everolimus. I think personally, I would simply try with tacrolimus and MMF rather than everolimus earlier on, and maybe think about everolimus after 3 months. As a renal sparing, I've not used it so early on. I think in the long run, everolimus with tacrolimus would be better than everolimus with MMF, because you could even maintain lower levels of tacrolimus when you're using everolimus than with MMF.
The one area is we see patients with diabetes, they have mild proteinuria because of diabetic nephropathy. That sometimes can aggravate after everolimus. But again, so we need to improve their glycemic control. That can also improve your
and also patients with proteinuria is a big problem, isn't it?
Yeah.
Here's a question on simultaneous liver kidney. What is your strategy?
Simultaneous liver kidney should be managed as liver alone. Do not listen to your kidney people and keep them on a higher immunosuppression. The liver has a protective effect on the kidney for sure, particularly if it is from the same donor in the cadaver. But even without having in the same donor, the liver absorbs a huge amount of preformed antibodies and things. So simultaneous liver kidney patient should be on the same level of immunosuppression as a liver alone patient, rather than on a kidney alone patient.
Prof, there's another question on intraoperative bread. What's the dose is the dose same in stable cirrhotics and in ACLF?
Yeah, I
We,
think 500 milligrams is a good dose. I wouldn't go below that.
There's another question which says, how commonly do you see steroid-resistant rejection, and how do you diagnose and manage that?
I mean, it's steroid resistant rejection. First of all, you need to have a biopsy before you start treating, because they will have the severe rejections are the steroid resistant rejection, aren't they? So they will have severe abnormal enzymes. So you need to differentiate them from others. So you should really have a biopsy in the first instance. And if you have given 3 doses and the enzymes are not, generally the enzymes will fall, not to a good level. They should rapidly fall. But after the 3rd dose, and you think things are slightly getting better, and on the 4th day they start rising once again, you might try 2 more doses of pulse steroids. And if that doesn't bring the enzymes down and the bilirubin is starting to go up, I would say it's a steroid-resistant rejection. But before you want to treat them again, you have to have another biopsy. These ones you can still treat with another cycle of steroids, 3 doses subsequently after 3-4 days. But beyond that, I mean, most of them should respond to that. But beyond that, you have to resort to antibodies, ATG or something like that. But I can tell you something. This is for all of you to hear. In the last 35 years, I have used OKT3 twice and ATG once.
What is your thought about Simulect in these kind of patients?
Simulect later on for steroid
Yeah,
resistant rejection.
right.
I don't think it's indicated later on. Is there? I don't know. Dinesh,
No,
Simulect
so,
for later. Pardon?
uh,
We
so
had
we
everolimus.
we use more mTOR inhibitor.
Yeah.
So the idea is to treat the acute episode and increase the baseline immunosuppression.
We would add everolimus, obviously, but Simulect I don't think works for
Change MMF to
rejection.
everolimus. That works.
Never use Simulect for rejection.
The next question is, what is the basic trick to differentiate between cholangitis versus cholestatic feature of rejection when we will do biopsy?
I mean, I think if you want to differentiate, I mean, cholestasis is more often due to sepsis than due to rejection, because in rejection causing cholestasis, I mean, see, it's very difficult in the early postoperative period, because there will be cholestasis as a result of either small foci syndrome or hyperperfusion, sepsis, rejection. I mean, there are so many different things. But when somebody's got a nice stable graft function, everything is falling according to let's say a living donor transplant, the first day AST is 300, and every day it's dropping a little bit, and until day 5, day 6, and then day 6 or 7, you see a failure to drop further, or a slight rise in the enzymes without even the bilirubin doing anything. You should suspect rejection in those patients. I'm not saying you should immediately act. At least have it in mind, and then look at the next day's enzymes and see. When I was once teaching with Subhash Gupta in Delhi, I think in ILBS, and I gave this scenario and put a graph of enzymes falling every day. until day 7. And then on day 7, the enzymes has gone up from something like 80 to 110. And then you wait, and then the next day it's 160. What is your diagnosis? I would have said for years together, this is suspected rejection. And I mean, I wouldn't use, in the UK, we are not used to treating them without biopsy, but here maybe you would treat them and see, at least give 1 dose of steroids and see what happens. But to my surprise, I learned something. Subhash Gupta got up and said, it's an anterior sector venous outflow block. I was amazed because I never thought about that as a possibility for sudden increase in enzymes. I guess your ultrasound scan will, I mean, see the rule for diagnosis in the early days of rejection on day 7 is that you must exclude vascular abnormality. So you do a Doppler, make sure the artery is okay, is what we always say. Make sure the artery is okay before you're thinking it's rejection. Now, with the living donor world, we need to tell the juniors, make sure that the artery is okay and your anterior reconstruction is not blocked on day 7 before you actually think it is rejection. But biopsy is very important. We still do a lot of biopsies in patients because if you have a confusing picture of cholestasis in the immediate post-transplant period, they always have slightly abnormal enzymes as well. The enzymes never settles down. And therefore, it's very difficult to, if things are not continuously settling down day after day, or they are stuck, I think you need to be able to diagnose rejection. And the only way to know is a biopsy. And biopsy will differentiate between cholangitis and cholestasis of sepsis.
Yeah, sometimes actually when you do the biopsy, you just see a bland cholestasis and there's nothing else. I mean, what is your thought on those kinds
If there is no inflammation and only cholestasis and bile plugs, you would never treat it with steroids. It invariably is graft dysfunction or just sepsis, low-grade sepsis. So you would never treat somebody for rejection if there is no inflammation. That is why it's important to do the biopsy.
So the other question is, when should we hold immunosuppression in LDLT during first month? Septic shock, severe neutropenia, diarrhea, or any other situation?
Yeah, I guess so. I mean, if there is a septic shock and the patient's inotropes are going up in a big way, I think there is sense in withdrawing immunosuppression and keeping them on. Most of them will be on steroids anyway, on stress dose of steroids. You probably convert them into hydrocortisone, and they'll be receiving reasonable dose of hydrocortisone. And therefore, I'd be happy for immunosuppression to be stopped in those patients who really have high dose of inotropes and are really unwell.
Right. In the similar lines, there's another question which says, do you believe in concept of immunomodulation in sepsis, where administering the same dose of immunosuppression is assumed to reduce the risk of sepsis-related effects and organ dysfunction?
What do you mean, carry on with the same level of immunosuppression?
Yeah, I don't think I would do that.
It might only change how the patient's reacting to the sepsis, but I think that's not a good idea.
Dinesh, you have to say something on that?
So in sepsis, okay, it's mainly you're talking about neutrophil and monocytes, macrophage, that's working on. Okay, that's causing the trouble. Whereas when you talk about immunosuppression, it's all about T lymphocytes, T cells. Okay, so in sepsis, you need to understand the basic the drug concept, which I in the first few slides. So it's anti-metabolites that causes more sepsis, and obviously corticosteroids, they are at risk of sepsis. I think tacrolimus and sepsis, I would say it's just too overstated. Maybe we can just reduce the dose rather than stopping it completely. But whereas anti-metabolites, which works on all the cells, not just the T lymphocytes, we need to modulate them. We need to reduce the dose or stop them, but not reflexly stop them. Probably in some mild UTI and all, you can just reduce the dose of MMF, continue the tacrolimus, and then see how it goes. Whereas in the other scenario, it's somebody with septic shock on inotropic support. Obviously, then the modifications are different. So that's what I'm saying. So rather than touching tacrolimus, probably we can.
Yeah, I think we have always lowered tacrolimus to a very low level rather than stopped it.
Yeah.
I mean, there's another question which says, is hydrocortisone indicated as an immunosuppression in sepsis without shock? I see this is turning it around a little bit, twisting the words. If the ICU consultant is starting hydrocortisone for severe sepsis, with shock, then I'm saying then you don't need to have the steroids there, and either very low tacrolimus is indicated. But you don't substitute your steroids or anything with a hydrocortisone in a patient with sepsis without shock. I mean, I think they would have anyway a low dose of immunosuppression and their steroids. So the hydrocortisone is not the one that we start as clinician for patients as an immunosuppression, but I'm saying the hydrocortisone started by the intensivists in patients with shock will serve as a substitute for your steroids, is what I'm saying. It's just looking at it the other way around. I think we should do the case presentations.
Yeah.
And
Yeah, I mean, we can take the questions after that as well.
Okay. Naveen has been waiting for the slide.
He's been changing. Naveen, please start.
Good evening, sir. And at the outset, I just want to thank the team LTSI for this opportunity. Today, we'll be running through two case scenarios, which we have already discussed. Actually, a part of this post-presentation discussion was on these case scenarios. So we have selected two more or less ideal case scenarios, but whereas the management is not the same. So we'll just go through it. So here is the first case.
You're drawing on your...
It was not me drawing. I don't know. I'm sorry, sir. Okay,
There
sir.
is a button called annotate. It's better not to touch that.
Okay, sorry. So here's the first case scenario where this is a patient, 31-year-old female from Maldives, background ulcerative colitis for 20 years, very well controlled on mesalamine. In 2018, during a routine screening, she was diagnosed to have a chronic liver disease, and it is possible of primary sclerosing cholangitis because the rest of the workups were negative, and she was asymptomatic initially. Since 5 years down the lane, she started developing symptoms of itching, which was initially controlled with UDC and cyclical antibiotics. Later that year, she's developed intractable itching. So they did a MRCP, which showed a distal long segment stricture, dominant stricture. So tried to do a ERCP and stent, a CBD stent was placed, but it subsequently migrated. So 1 year later, down the lane, she developed cholangitis. That was the first episode of cholangitis. And 3 months down the lane, again, there was a second episode of cholangitis. And with this history, she presented to our department. So the initial evaluation, she was not icteric, but she was febrile and tachycardia was there, and she had a large liver. And the investigations wise, she was not having any features of portal hypertension. Platelet counts were normal. Bilirubin was not that high, but there was a high alkaline phosphatase and GGT. Otherwise, preserved liver function and the MELD score was 11. So this was the cross-sectional imaging where the CT showed there is evidence of chronic liver disease. There is caudate hypertrophy. There is irregular liver borders. And the MRCP imaging showed there is an irregular small depth. Predominantly, it's a PSC where you could see the bile ducts are irregular, and we could see the intermittent bleeding and dilatation in between. So our final diagnosis is what's a primary sclerosing cholangitis. She had 2 episodes of cholangitis by now. There is no evidence of cholangiocarcinoma, and she had also an ulcerative colitis, which is under remission with a low MELD score. So primary sclerosing cholangitis with recurrent cholangitis, we decided we should offer the liver donor liver transplantation, and subsequently she was transplanted 2 months down the lane. So just I want to important intraoperative events. She had a standard anastomosis, right hepatic with IVC and V5 V8 construction with MHV, and a single portal vein RPV to the MPV, single artery anastomosis. And as in primary sclerosing cholangitis, we did a hepaticojejunostomy and not the duct-to-duct anastomosis. So she had a new rule, right hepatic duct was connected to a new rule, and the graft GRWR was Dyson 1.3, and the Doppler was fairly normal. There was no requirement any portal flow modulation. So if you go by the day of the lab reports, on the day of transplant, everything was fine. So as usually we give in the anapathetic phase at a high dose of methylprednisolone, 10 mg per kg, except for nothing we are given on the day 1. So day 2, we see the trends. We slowly start the tacrolimus and we start with 16 mg of methylprednisolone. And if you see the first days, there is mild transaminitis, which we usually expect in the first couple of days due to the ischemic reperfusion injury. And just we are for. And when we see through the days, the next few days, the enzymes are gradually settling. There is not much of an issue. And we have started, as per the protocol, our institute protocol, we have started MMF on day 4 because everything seems to be going well. And she was transferred to ward. And now, the very next day, you can see there is a gradual rising in enzymes and there is a gradual rise in bilirubin. So this is the ideal case scenario what we see. The enzymes are almost doubled and there is a doubling of bilirubin. So on day 1, how we approach as a unit is again probably a mild amount of rejection. So we slightly increased our steroids to 20 mg. And you see the tacrolimus levels, how we adjust. The first dose, that is the morning dose we give, and we get the TAC level later during the midday. You get the TAC levels. So usually we change accordingly to the night dose we alter. Okay. So we this the same day when the reports got deranged, the morning dose was around 0.5. So we got the TAC level of 6.5. So we wanted to, we thought we are dealing with the rejection here. So we slightly increased our immunosuppression, slightly on the higher side, with both the steroids, and waited for the next day. And you see the reports next day where there is almost bilirubin is more or less static, but the enzymes are still on the higher side. So now the ALT has approached more than 500. And now if you see the TAC levels usually maintained around 10 in the first week. So it's slightly on the lower side. And now, so now we have adjusted the steroids, increased the TAC level on previous day. Still the enzymes didn't settle. So what are we dealing now? How do you approach this altered LFTs in the post-transplant period? So if you ask, many things we need to consider. It's not you just simple LFTs alone. What we think is the timeline from the transplant. There are differential diagnoses based on what happens in the first few days, later 2 to 3 weeks later, and some 1 to 2 months later, and also the history as well as the clinical presentation, how the patient, the rejections get happen. And this was an ICU care, so we don't what is happening. But if the patient is coming after a couple of months, then based the history, the travel histories or some histories or changing the immunosuppressions, these histories matters, and the way they present. And also the pattern of LFTs, whether it is a predominant hepatocellular pattern or predominant cholestatic pattern, these also help to some extent. And significant perioperative events are more important when, especially in the first 2 weeks of deranged LFTs. And as well as the risk factors, whether donor as well as the recipient, a borderline donor or the sick recipient, all these factors matters. And also the last is the immunosuppression, how we are changing the immunosuppression. Still others are also there, whether what is the possibility of sepsis and what kind of etiology of the primary liver disease. Here, as in our case, it was a primary sclerosing cholangitis, likely an autoimmune related background. So the possible differential diagnosis based on the changes for the immediate first 2 weeks with the predominant hepatocellular pattern is the first and foremost is always the ischemic reperfusion injury, which usually happens in the first 24 to 48 hours. Sometimes may go up to 3 days. And the second is the probable sepsis, and more concerning is early allograft dysfunction of the PNF primary non-function of the graft, and hepatic artery thrombosis, where the enzymes go much higher fold, and also bilirubin doesn't settle, your coagulopathy worsens. So these are more dramatic situations, but usually that is not the case. Usually it is either the ischemic reperfusion injury or the sepsis, or sometime later you may have the 2 to 12 weeks, usually the sepsis, rejections, and the viral infections. Even later, beyond 3 months is where the recurrence of the primary disease, where if the patient is an alcoholic, whether there was recidivism or some drug-induced liver injury, viral infections, or the NASH, and beyond that is usually the recurrence. You see here, rejection, drug-induced liver injury, sepsis usually can present as any pattern and also at any time frame. So it all depends. You cannot rule out these things at any time frame. So these also always should be in the back of the mind. Biliary usually present as cholestatic pattern, usually in the initial year, 1 to 2 years as the biliary. And first weeks, it should be either the bile leak or the small foci syndrome or predominant sepsis or D-leak will be the cholestatic features. And beyond later, it will be usually the bile leak or the biliary strictures with drug-induced liver injury. In the long term, it can be the recurrence of PBC or the PSC. So this is in general, how we should approach a patient with an altered LFTs. So what are the possibilities now? In my case scenario, where the patient is a young individual, the background PSC, now within day 5 or day 6 having present with a higher transaminitis. So again, as per this, we'll go over the surgical complications, whether it is a delayed IRIs or the vascular complications, or am I dealing with a biliary complication here? And is it a sepsis? Is it a rejection? Or it is a drug-induced liver injury? So this is how we usually need to investigate now. So I have a patient who has a deranged LFTs. So what are the basic tests that is required? Is a CBC as well as the serial LFTs given idea. CBC is basically to say the trend of whether you have dealing with any infections, to see your total counts, either rapid increase or rapid decrease, or the platelet counts going rapidly down. Also says sometimes you are dealing with an infection. The first row basically, or the basic test which we need at this point of time. Second row based on the clinical situation, and third row is only when it is warranted. So the blood drug levels, obviously we used to check the tacrolimus levels. Everolimus too early now, but I'm just saying in general we need to check the drug levels. And serology wise, because it's a predominant transaminitis, we need to check the viral serologies, hepatitis B, A, and E, and sometimes if it is hepatitis C. And the basic imaging we require is an ultrasound abdomen with Doppler. As Dr. Rayla correctly pointed out, on day 5, day 6, it can be even the vascular complications that are more common. And based on the things or additional information, if you feel sepsis, your cultures are important. If you feel the graft is struggling a lot and you are feeling the liver is going for a failure, you may need an INR to guide you, even ammonia at that point of time, or the additional serologies, CMVs as well as HCV. And whenever you suspect any vascular pathology of the thrombosis, you should cross-check whether contrast CT abdomens, and maybe MRCPs if at all required in case if you're suspecting bile leak or the biliary pathologies. Very rarely you may need an ascites screenings and additional serologies. So what we did in our case was, so it was a transaminitis. We ruled out the viral hepatitis A, E, B as well as C. All these virals were not detected. And then we did a USG hepatic Doppler. There was hepatic veins were showing triphasic, both the veins showing triphasic flow. Portal vein was good. There is no hepatic artery resistance and flow is good. There is no IHBR, no ascites, except for minimal cut surface collection, nothing in the ultrasound. So as discussed earlier, and the things that transaminitis already the ALT has reached 500, and we decided to do a liver biopsy. So before I go to the liver biopsy, I just wanted to share this. This is a normal portal tract.
Naveen, can I
Yes.
stop you for a minute?
Yes.
I mean, personally, I think a Doppler is important, and you had a list there. Under 1 week, you didn't put rejection there actually. So is this graft dysfunction? This is not graft dysfunction, because If it is graft dysfunction, it should start from the day of the surgery. This is not primary non-function or primary, delayed graft function. And the other thing you put there was, can you go back there? So it's very easy. It's not ischemia reperfusion injury, because ischemia reperfusion injury should start on day 1. So it's not hepatic artery thrombosis because you have done a Doppler. It's not bile leak. You don't see anything in the drain. I mean, small foci syndrome, you will know because GRWR is 1.1. Drug-induced liver injury in the first week, we are not using anything that causes cholestasis or enzymes. So my differential is between sepsis on day 7 and a rejection. Sepsis is a real possibility, but then the patient's not unwell. The patient's actually in the ward. If it is rejection, it's actually quite high rise in enzymes. So I would say it's either severe rejection or sepsis. And therefore, I would want a biopsy before I want to treat it. So let's look at your biopsy. So let's not complicate it with A and E and, virus. All of that will come into play only when your treatment is actually not working. Do you understand? When you're not diagnosing. Yes. The first thing is to really exclude between sepsis and rejection. Okay, let's look at it. Because if you put all of this, people will get confused. Should we do all of this to exclude all of this before I want to even think about rejection? I think you should, on day 7, enzymes rising like that, you should think about vascular problems or rejection. So ultrasound is very easy to exclude vascular problems, and therefore think about rejection or sepsis. Those are only 2 things that will go through my mind. Okay.
Okay. Yes, sir.
This may be more relevant when the patient go home and have some sort of jaundice or graft dysfunction.
Yeah. Viral hepatitis is later.
Later stage.
Right. Sure. If they come back. We're talking about day 7 abnormal LFT.
Yes.
Okay, go on.
So before going to the original biopsy, I just wanted to give a brief about the normal biopsy, liver biopsy, what we actually see. So this is a normal portal tract. When we are dealing with rejection, and what we actually should be worried about is the portal area. So I'm giving you very basics about the liver histology. So in portal tract, you see 3 things. That is, the bigger lumen is what is the vein. It is the portal vein, venule actually. And this is the bigger venule, which are baseline what of the nucleated cells in the basement membrane. And you see 2 other structures. One is thick walled. This is the artery, and it is always accompanied by a duct, usually a duct. And this duct is usually have a necklace pattern of arrangement of the nucleus with a central lumen. So there is a duct, there is an artery, and that is a vein. These 3 constitute the portal tract. And surrounding, you see the hepatocytes, which are normal. You see the normal ground glass appearance, not the normal ground glass appearance, normal appearance of the hepatocytes with the nucleus. Everything's fine. This is the normal portal tract. So these are the 2 things we need to see, and also a central vein, which I will show it later. So in our case, this was the biopsy. When we did the biopsy, it was this is the same portal tract area. At least we can say there is a plenty of neutrophils. All these are, we're not able to see the portal tract structures. We are not able to clearly identify where is the center, where is the portal venule, where is the duct, and where is the artery. All these are surrounded by only lymphoplasmacytic neutrophils and plasmacytes. It's a dense portal inflammation. If we even go slightly deeper, we may say this is the area of the ducts. The duct is full of inflamed, and also we cannot see the much of the vein. At least the vein is somewhat visible here. It's full of, it is damaged, and it's a basically I want to say it's a dense portal inflammation with the ductal damage as well as the central venule damage. And here is the central vein. This is another area where they also shows upliftment of the endothelium from the central vein, from the basement membrane. This also suggests a severe venulitis. So the graft biopsy of this was the central vein, and the final, it's more of a moderate to severe rejection. There was not much spillover of the inflammation to the adjacent hepatocytes. and the ductal damage was not also categorized as severe category. That's why it was coming almost, the RAI score was borderline between 6 to 7. So it's a moderate to severe rejection.
I would have
And
called it a severe rejection. I mean, clinically, biochemically, it's severe. And I think you said there is no lobular component. If you go back, you see a lot of lobular inflammatory cells as well, scattered on the right side. I don't have an arrow. If you look at the 3 o'clock
this is
position, so that's not a portal tract, but there is inflammation there. So what is not there is the spillover on the portal tract. So you got a very well-defined portal tract with what you call no piecemeal necrosis, but that you see mainly in a hepatitic picture. So it's just an enlarged portal tract. You hardly see a normal bile duct there, you have to imagine a bile duct being destroyed. Maybe something with a mild or moderate would have been better. But this is just densely infiltrated lymphocytes in the portal tract. I wouldn't hesitate to start 1 gram of methylprednisolone on this patient. Okay, let's see what happened. We need to move on. Let's just keep to the clinical findings alone rather than some basics.
okay, so now we know we are dealing with a rejection, severe rejection. So we started with pulsing, which started with methylprednisolone, and this is the day 1, and POD 8 is after this. So the patient received 1 dose on POD 7 with this LFTs. Now this, after the response to the 1 gram of things, you see LFTs are slightly increased, bilirubin is also slightly increased, but there is not doubling as how it was the previous way. So there is some response to the pulsing. So we again went ahead with 1 more gram. You see now the LFTs are almost static, and although they're slightly increased, so we repeated on 3 day also, we just went with 1 more gram, and you see there is a good response now. Enzymes are settling down, and so we tapered down the steroids. We reduced to 500 mg for the next couple of days, and also with this pulsing,
but
we keep as
would you describe this? Would you describe this as a response to steroids? I wouldn't.
I won't say an excellent response.
This is not a response to. Let's see what happens. Okay, you go on. I don't
Yes,
remember
sir,
the case.
that's
So, yeah, I'm just looking at it in a very neutral manner. I would say that this patient has not responded to treatment. Okay, go on.
So, and the tacrolimus we want to maintain around between 8 to 10 again with the thing. So we just keep on adjusting the tacrolimus. So until day 1, we thought there is a partial response. When we tapered, the very next day, if you see the response, again there is a rising bilirubin, rising enzymes, and now the ALT again started to rise. And now, so today, now we have a patient where patient had a severe rejection on day 7. We have done a pulsing for 5 days, 3 days plus 2 days of reduced pulsing doses. Initially, there is a partial response kind of thing. There is, at least the enzymes were settling, not totally settled. But again, after 5 days, it is again showing a rising trend. What now? So what are the possibilities now? So whether are we dealing with a sepsis again, whether now the patient is on high dose immunosuppression, we have pulsed him a lot, and now are we dealing a sepsis, whether the patient has aqueous sepsis now, or is it a steroid refractory rejection what we are dealing now, or is there any superadded vascular complications, new complications, or we just incidentally picked up now? So
I mean, I would call it a refractory rejection based on the biopsy that we saw earlier on, because the way this patient presented was a severe rejection. So your diagnosis of moderate to severe rejection was wrong, wasn't it? It didn't respond well to treatment. Yeah, I would call it a severe rejection which has not responded to treatment. Okay, so what did you do?
It is actually a steroid refractory rejection, and we actually went ahead with a repeat biopsy, because we, even before pulsing or thing, we just wanted to know that we are not dealing with sepsis anymore, or there is nothing new now. So we did a re-biopsy. This was the second biopsy within the 6 days of the first biopsy. Now, if you see the same, you see it's even more denser. The portal tract is even more denser. And now there is definitely a spillover of the inflammation to the adjacent parenchyma. Even now, we cannot see any portal structures. And if you see the central venues, even there, they started getting more involved. And there you can see a lot of necrosis in the central lobular area. That's why we expect a lot of hepatocyte damage now, which was not the case. Even the portal tract shows a lot of necrosis now. It is even more severe rejection as of now. But at least we have ruled out there is not much of cholestasis, which goes with sepsis, or we are not dealing anything else. It is even dealing a more severe form of rejection at this point of time. So this is the day POD 13 was the day where we did the second biopsy, and we see it was even on the very next day we come to know that it is a severe rejection. So again we are thinking a steroid refractory rejection, but even going to the next line of treatment, we want to try steroids again, usually for 2-3 days to see the response. Again, if you see day 1, it did not respond. The bilirubin seems on the rising trend. Enzymes are also on the rising trend. Even on day 2, until after 2 doses, it reached the maximum. The bilirubin was maximum 29.8, and enzymes almost close to 2000 now. And also, what we also wanted to increase the TAC levels, keep the higher dose of immunosuppressions here. And only thing we decided to go for 1 more day of pulsing, because we know there is a lot of significant necrosis this time. So we don't expect the necrosis to improve all over a day. So we need the bilirubin will be high initially. The enzymes might go high initially, and later it might settle. So we just tried with 1 more dose of 1 gram steroids. Then things eventually started to settle. So, and we have already, by this time, we have already pulsed them with almost close to a week, more than a week now. So we gradually reduce the steroids. If the thing seems to be settling every day, so then we maintain a high dose of steroids. Usually we maintain a 20 mg initially. So here we kept a very high dose of steroids. We maintain the TAC level around 10, and we just wanted to give some time. So by this time, gradually the graph started to settle. So luckily in this case, where we had a steroid refractory rejection, where otherwise the next options are much limited, we persisted with the high dose pulsing dose of steroids, and luckily this time we were able to get. So our take home message in this case is usually not to panic, and we don't lose a graft within a day, and just avoiding this is finding a balance between optimal immunosuppression, maybe high dose immunosuppression, and also at the cost of getting into sepsis. So balancing these two, and with some logical reasons, we may eventually get over the graft will recover. And this case, also we should think this patient has an autoimmune background, just has basic PSC. So this is also a reason why the patient has a higher, like the patient has a basically higher immunity to start with. So the rejection is always the first diagnosis in this case. Although we keep the other things to keep it interesting, although we always, as Prof rightly pointed out, it was the rejection from day 1. So you want to add anything, sir, or should we go to the next case?
Nothing. I think 2 cycles of steroids is acceptable. But 5 days is probably not acceptable the second time around, but that's what seemed to have. You've given for 4 days on the second time around, maybe in desperation.
Yes, sir.
I don't know. And
What I
would
see
for 3 days.
Probably the third dose of the second spell actually started working. But after that, things have changed.
Yeah, I agree. Because when you're giving 500, the bilirubins actually started falling. And the enzymes have fallen. The AST is half from 952 to 417. You have still given the 500 milligrams. So the day 17, 500 milligrams was probably not necessary.
Also, it's important to give antiviral and antifungal prophylaxis in these patients to maintain higher immunosuppression.
I have a quick question here. I mean, here we gave 4 grams cumulative dose of steroid, then we biopsied, then another 4 grams was given, I mean, do you think there is an upper limit of steroid that can be used?
Yeah, that's what I said. Twice is the upper limit. Now, if this didn't settle down, you wouldn't be using steroids again.
Right. And the second thing is, I mean, regarding the C4D stain and donor-specific antibody, with this kind of rise in enzymes, and I was looking at the portal flow, which mentioned a 16 velocity of portal flow, which is much less, and it's still hepatopetal, but then you would worry that this can get into hepatofugal with that velocity. So,
Yeah.
I
Oh,
mean,
the livers get very stiff, don't they? When you
yeah,
have to do a laparotomy on these patients, the liver will be very solid actually. With severe rejection and cholestasis, the livers get very stiff.
right.
Yeah.
So how about doing the
Wants to
C4D and DSA in this one?
I mean, they would have done it. I'm sure the second time biopsy, they would have done it.
We did those COD stainings. They're all negatives. So I just wanted to not deviate from this things. The other things, when we do a steroid first, this is how our approach to a steroid resistant rejection would be, where we will do the C4D staining, and we also check the donor specific antibodies. We have to make sure that we are not dealing a AMR here, like autoimmune mediated rejections here. And I just didn't want to deviate from the topic. It was done and it is negative.
So, Abhidip, C4D can be positive even in severe T cell mediated rejection. Presence of that alone doesn't, make you diagnose of AMR here. So,
Yeah, I agree. That is the reason I asked for both C4D and DSA. I mean, you have to have 2 or 3. So, yeah, I mean, I think, Dinesh, if you have to just summarize a take home for all the fellows and the faculty in this kind of a situation.
This is a young lady who underwent liver transplant, living donor liver transplantation for autoimmune related liver disease, that is PSC, and she had an early increase in enzymes. Systematic approach is very important in these patients. First, do a Doppler, make sure there is no vascular issues. Then you plan liver biopsy. Liver biopsy here showed acute cellular T cell mediated rejection. So she received methylprednisolone 3 grams, sort of 1 gram for 3 days, but no much response. So therefore, she had a repeat biopsy, one to see the histological response, as well as to reconfirm the diagnosis, also to see whether either add-on factor. So this is why we should do a repeat biopsy in this scenario. And fortunately, she responded well to the second dose of pulsing. And her tacrolimus baseline immunosuppression, you can see, is little closer to the 10 rather than closer to 6. So this is very important to maintain these patients. Obviously, long term, we should not taper steroids rapidly in these patients. So you should taper a little slowly so that the graft adapts, and then we maintain normal allograft function, and keep them on 5 milligram prednisolone and keep them on a little higher immunosuppression as she is young, likely to reject. Autoimmune liver disease is the background. And also protect them with calcium and D3, as Prof. Rela said, and maybe a PPI over a period of time. And we should also, in the early phase, when they receive high immunosuppression, you should cover them with antifungal and antiviral medications against CMV. Also, there are patients rarely we do see with PCP. So therefore, bacterial prophylaxis also, if they receive a prolonged high dose immunosuppression, you should cover them with protramoxazole as well.
Great. So there are a couple of questions. One is, what is the overall complication rate of liver biopsy in your center? I guess most of us now do a transjugular liver biopsy, so not much of a problem. If you have any different take on that, so you can add that.
Oh, we only do percutaneous liver biopsy. I don't think we have seen much bleeding.
Right.
I can tell you that when people say, if you don't have a perfect outflow and have a congested liver, then it is scary to do a liver biopsy. But if you have a good outflow, I don't think it's a problem. So that is the worry for most people. We do we, Dinesh? I don't think
No,
we do.
Prof. No. We do only percutaneous, Prof.
We only do percutaneous liver biopsy on these
We
patients.
haven't seen
And
it.
I don't think we have explored any patient or embolized any patient for bleeding.
Yeah. So,
Yeah, I guess these days I mean, IR guys can follow the biopsy track, and if there is any evidence, they can just
Plug it as
put a
well.
gel for. Yeah.
Yeah.
So how about adding azathioprine in this setting?
Or
In fact, Prof, do you want to?
no, I don't know. You say. I mean, I don't
So
think
in
we have
fact,
thought about it.
azathioprine is the drug of choice for patients with autoimmune liver disease. You know, we use extensively in the pre-op period. In fact, in early 2010, 2004, when I was in training, it's actually azathioprine was the second line drug. So the protocol was you start them at tacrolimus, you start them on steroids, taper steroids slowly, and if they have rejection, add azathioprine. Azathioprine is more well studied in this group of drug. But once again, if you look at the difference between azathioprine and MMF, they are actually more or less similar group of drugs with similar efficacy. And MMF in the pre-transplant phase works when used in patients with azathioprine intolerance. Okay, but in the post-transplant phase, we are more comfortable using MMF. So that's why we stick to this drug. And there are patients where we switched over to azathioprine, particularly with this sort of autoimmune hepatitis recurrence, and they do well actually. So
Yeah, I
I kind
want
of agree
people
on
to
the
remember
use.
that this is not a common event. I mean, it's been presented because this is rare and a difficult problem. The question of what is the maximum steroid dose would you use? I mean, it also depends on how the patient looks. If the patient looks septic in any way, you're not going to even give the second round of steroids. I would have done the 1 gram, and if there is no response, maybe like they have done, maybe I've told them give another 2 days of 500 milligrams. The second time around, I would have given another 3 grams, and that would have been the end of steroids. After that, you sit tight and see what happens, rather than really keep on immunosuppressing them further. My limit would be, I mean, if you exactly ask me I've never thought about what the limit is. If you calculate my viewpoint, my limit is totally 7 grams of steroids over a 2-week period.
it's an average of 6 grams, about 3.
Yeah, usually it's
minor.
only 3. Generally, it's only 3 plus 3 is what we generally follow. So that would be 6 grams. This has probably been an exception. But anyway, it
So,
seemed to work.
yeah. Naveen, do you have another case to discuss, or we can quickly
I
take
think we
more
should
questions?
finish it. We're already 2
Yeah.
hours out.
Right. So,
Let me see if we are doing well by looking at the number of people who are still
yeah, we
there.
still have 98 people.
Okay, all right.
No attrition.
No, it went up to 123. But like, I mean,
For the other case, we can just discuss briefly, because it's very important.
What is the case?
It's similar allograft dysfunction, but slightly different diagnosis. I mean, you can present only the gist, actually.
Just present the case, only the clinical findings. 5 minutes, I give you 5 minutes.
I mean, things logged up.
He's gone. If he's gone, that's great.
Yeah, sure.
No, it's actually great. I mean, there are a lot of more scenarios which we can address, like if these patients are undergoing various other surgeries, what should you do with immunosuppression? Or no, Naveen is back, and Naveen, you want to quickly do the
Just
summary of the
present
next case?
Present the case in 3 minutes. Just the slides.
I mean, the post-op we can present, actually, not the pre-op.
Just the history and the liver function tests.
I mean, Mike.
Naveen, unmute yourself.
Yes, sir. Sorry, sir. So here is a patient who is a 47-year-old male, chronic hepatitis B, non-cirrhotic HCC, underwent hepatectomy elsewhere. Post-hepatectomy, he developed recurrence in the right side of the liver. He had a left hepatectomy in Kolkata. Post that, he developed recurrence within 3 months in the right side of the liver. He approached us. So otherwise, the FP was still high. The DNA was on treatment. DNA was getting negative. It was initially log 8 before treatment. So we can just see few lesions, but there were 4-5 lesions on the right side of the liver, which was slightly
Let's
arterial
go
enhancing.
to transplant. We were dissecting, mainly talking about rejection now.
Fine. So he underwent a salvage living donor liver transplant subsequently. Though there was a good GIW liver, the graft was good, and no portal flow modulation was required. So a similar case scenario. So here, same, the patient's graft function was initially good. Day 4 till everything was going smooth, and we shifted the patient to ward. And then the day 5. So there is a mild increase in the enzymes here. Again, close to doubling of the enzymes. Bilirubin is static. So as we again slightly wanted to increase the dose of tacrolimus observed for a day, we thought here also it could be possible rejection here. Again, the very next day, day 6, if you see, it has not improved. The enzymes continue to rise. ALT is close to doubling. Bilirubin is still normal. Even we had a good TAC level. So again, on this situation, what are this almost a similar case scenario as the previous patient. As again, there is, we always think.
Yeah, go on. Let's not talk about this. So if you look at those LFTs, I would say that it's very similar to the previous case, except it's 1 day before. Isn't that right?
Yeah, exactly.
Or 2 days before, slightly earlier.
POD 7, it is POD 6, yeah.
Yeah, POD 5, 4, 5 may be okay for rejection, but generally it's 6, 7. Okay, go on, tell us what it is.
So here also it was, we did a liver biopsy. Okay, so if you see compare the previous year biopsy, you just see this is the portal area where there is mild like portal inflammation is there. But if you compare, it is not as dense as the previous picture, but there is significant lobular activity here. And the patient has both lobular as well as the portal activity. Portal inflammation is there. But if you see you can see the central vein clearly. There is no evidence of any endothelitis. You can see the arteries. You can see the ducts. None of the ducts are not damaged. Just a simple mild portal inflammation, and also equivalent as lobular inflammation. So this is a patient who has both a lobular hepatitis. It is a case. It is what we can say is at least we are not dealing rejection here, because for that amount of enzymes to go to close to 500, you expect clinically, you expect if at all it is a rejection, it should be a severe rejection. But the biopsy doesn't favor. It is even, we can say it's mild in case if you want to say term it, but it is just a mild portal inflammation, which does not explain the degree of transaminitis what the patient has.
Okay, go on, tell us
and
what it is.
also supportive features, there is evidence of lobular hepatitis. So what we actually don't here, at least we are not dealing a case of rejection here, although the enzyme patterns were almost close to the same. So we went for the extended workup, like that was the case we discussed last time, like what we have to do now, that we have to do because it is a predominant lobular hepatitis, what we actually do is hepatotropic viruses and atypical hepatotropic viruses. That's what we have to rule out. Initially, we ruled out all the hepatitis A and E, B, C. And now again, the dengue serology, CMV, HSV, we did one by one, because we are not we are very much sure we are not dealing with rejection. It's only some viral hepatitis. So if you see our plan of my initial management, we just stick to the steroids. We continued the same. We just followed. We didn't change. We didn't pulse the patient. But if you see the enzymes are gradually increasing trend, then we decided we will slightly lower the immunosuppression. Gradually, we brought down the TAC levels lower. We brought down the steroids level lower. And every day, it's not the day one we have all the investigations. We have sent the lobular hepatitis workup and we are still awaiting. And I've just shown what are the things that subsequently came negative by the end of second week. So by end of second week, we see almost all the workup, extended workup has also turned negative, but still the enzymes are higher. But what we are dealing is still a lobular hepatitis. So we thought of gradually lower this immunosuppression and observe. So by the end of third week, we got an external one viral alert. that was a parvovirus B19 got detected. So this was a sample which was sent in the second week, which was processed, and we got it later that the parvovirus B19 was detected. So we went, it was close to a tune of log 8. And then this patient in the meantime also had a gradual drop in hemoglobin. If you are, there was almost a 3.5 gram, 3 to 4 gram drop in the 1 week. So we felt that it was a parvovirus induced hepatitis with a gradual hemoglobin drop as well as a hepatitis. So this is the only case we have treated it with as a parvovirus in our institute, and we treated with IVIG, and the treatment is you lower the immunosuppression. That is the first treatment for parvovirus, and also if you are thinking it is damaging any organ, so you have to give an IVIG. This is a routine dose over the next 5 days. Then you see the things are gradually settled. So, and we reduce the dose of immunosuppressions. We slowly taper the steroids, and we prematurely stop the steroids early in this case. And we are just maintaining with the low dose tacrolimus. And everolimus was added after 3 months because it was a HCC recurrence, and even the biopsy showed there is a multiple HCC, not just 4 lesions. There were actually more than 10 lesions in the explant. So we started everolimus by the end of 3 weeks. So the take-home message here is, we have 2 patients similar profile, but when we know what we are not reading rejection, just we should not panic. Just keep the immunosuppressions low, as this in case, exactly opposite kind of treatment what we discussed in the previous case, and things will eventually give time for things to settle. So the take-home messages from these 2 cases is, we should have a systemic approach to deranged LFTs. We have to think about all the possibilities as in the case, and we should have a clinical lab as well as imaging correlation. Then only we should treat the patient. When you suspect clinically, you suspect rejection, then the biopsy favors rejection, then you treat. Or when you suspect rejection and the biopsy says no, then we should be good enough to think what else is the other possibility. So there should be a close clinical relation between all the 3. There should not be any hit and run approach. But just once pulsing, next biliary stenting, we should not do that. And don't treat any rejection without a biopsy. Thank you, sir. Prof, you want to add anything in this case, Prof?
No, I think you've been lucky. I mean, there are circumstances where we have treated rejection without a biopsy. I wouldn't say that we never treat rejection with a biopsy. It's all about timing. It's a bit of a surprise that we didn't think it is rejection. That I think biopsy really helped. The reason why I do biopsy is, if the enzyme rise was mild from say 90 to 150 on 7th day, I would have treated it like rejection. But the enzyme rise are very high, jumping to 300 to 600. I always think of other possibilities, really, because rejection never puts up enzymes unless it's a very severe rejection like we saw before. And even in those situations, I think it's useful to get a biopsy. A slight rise in enzyme from 64 to 90 to 110 on day 7, 8, I would have sometimes treated them without a biopsy too. And we have done that. Anyway, this is a good case to show that sitting around and reducing immunosuppression has helped. And I think it's helped in many patients.
Yeah.
Great.
Okay, all right.
Great. I think this was truly an outstanding session. And on behalf of LTSI, I would like to thank Prof. Shrela, Dr. Dinesh, Dr. Naveen, share those wonderful cases and a very concise talk by Dinesh. And as always, truly enriching words from Prof. And it's the experience of decades that we get to hear from you is always wonderful. And I think to all our participants, I hope the session was enriching. I think it was good enriching for me as well. And I think this is the beginning of LTSI Masterclass, and we hope to continue like this on every month. I'll be announcing the next Masterclass in the coming week, and we continue to do that every Wednesday, first Wednesday of every month, 7 to 9. Hopefully, we can continue to share this kind of knowledge, and which can help us in improving the treatment and care of our patients in future. Prof, any last words from you before we close the session?
No, well done is what I would say to you, Abhijit.
Thank you,
I
Prof.
think it
Thank you.
was very interesting. It's very practical. That's what was good about this whole session. And day-to-day management of patients and difficulties. So I'm so glad that so many people attended as well. I didn't expect that. I was thinking about some 20 to 30 people. But this is very good, and thank you for participating, and thank you for the opportunity to share our experiences.